Hello, everybody, and welcome to Pharmacology. We're going to start off with a little historical background, along with some terms that I would like you to remember, some terms I'd like you to be able to explain. The study of medicine, pharmacology. The term pharmacology comes from two Greek words, pharmakon, meaning medicine, and logos, meaning study. Dates back to 3000 BC, and there are examples of pharmacology in all ancient cultures, Egyptian, Mid-Eastern, Babylonian, Indian, and Chinese. Many of these so-called medicines that were used were thought to have magical properties, although some had definite physiological effects on the patient. And we'll get into one of those in a minute. Many of these early medicines were derived from plants. Now, when we talk about some of the medications being used, as I mentioned, many have a plant origin, but more recently, we're using broad categories of medications called biologics. We'll discuss biologics in greater detail when we talk about oncology and autoimmune disorders. Biologics are naturally occurring, they exist in our own body, and they've been found to be very effective in the treatment of cancer and autoimmune disorders. But getting back to the word pharmacology, and that Greek term pharmakon, meaning medicine, has an alternate term as well. Pharmakon can also mean poison, a substance that's able to cause disability or death. A poison is a substance that can cause disability or death. And I think, in a way, part of our practice as nurses is to ensure that pharma, that medicine has a beneficial effect that improves quality of life and does not cause any disability or death in our patients. So one of our broad goals is to help that client to safely and effectively take the medication and avoid any adverse effects. So pharmacology draws on chemistry, microbiology, and the anatomy and physiology of the body. We're going to be examining physical and chemical properties of medications at first very broadly, and as we progress through the semester, we'll be focusing on these physical and chemical properties more specifically. All right, so we're going to move on to the next slide. And I'm going to give you an example here of a plant that has been found to have some beneficial effects to the body. Now, foxglove is a plant where if you were to eat it, you'd probably get physically sick, experience some stomach cramping and diarrhea. However, it was found in ancient cultures that if you were to remove the extract from the plant, that this medication could slow down heart rate and help the heart to pump more effectively. Now, that probably reminds you of a medication I'm sure you've given in clinical several times already. That would be digitalis or digoxin, which has inotropic effects on the heart, which helps to slow down the heart rate and to help it more effectively pump, thereby being an excellent drug for the treatment of congestive heart failure. So some of those basic terms I mentioned before that I'd like you to be able to explain, things like drug. Drug is a widely used term. The terms medication and drug are often used interchangeably, but a drug is any chemical that can have an effect. So with this definition, a cigarette can be a drug. Alcohol can be a drug. It can affect our living processes. What we're going to focus on are these drugs that have therapeutic effects. Those drugs, so to speak, that can improve the quality of life or that can improve the health of the individual. Those that diagnose, prevent, or treat disease or prevent pregnancy. Now, some of the things we're going to focus on would be the mechanism of action of this medication. In other words, the means by which the medication exerts its effect. Now, effects can be therapeutic, meaning they improve the quality of life, and pharmacotherapeutics would be a term I'd like you to remember. It's the use of pharmacology in order to improve the health of the individual. So there can be therapeutic effects or there can be adverse effects, unexpected effects, sometimes very dangerous and severe effects. Other times, those adverse effects can be just simply annoying. Pharmacokinetics is a term that we use when we talk about how much of the medication gets to the site of action where it can exert its effect. Pharmacodynamics is still another term I'd like you to be able to explain, perhaps give an example of, if ever you were asked a question on a test. Pharmacodynamics has to do with the impact that the drug has on the body, the nature and intensity of the response on the body. This can be influenced by several different things. Receptor sites that the drug interacts with, and more on receptor sites in a little while. We'll be talking about receptor sites a lot. The functional state of the person. They have an effectively pumping heart. Are they able to metabolize medications to make them inert? Are they able to excrete medications so that toxic levels don't accrue in the body? They can also be influenced by what's called a placebo effect, which simply stated, it's like mind over matter, psychological effects of the medication. Some of the other influences concerning pharmacodynamics have to do with age. We absorb, distribute, metabolize, and excrete drugs differently when we're infants than when we're a middle adult. Different when we're older adults rather than middle adults. So age has an effect, gender has an effect on these processes, our racial background, finally our body mass. All of these can influence how medications can change our body. Okay, so the first of several slides on cellular receptors. Simply put, receptors are molecules, macromolecules, large molecules that exist on cellular surfaces. The receptors are usually made up of proteins with a channel, a pore, if you will, in the middle of the molecule. And when medications bind to these macromolecules, they cause a chemical or electrical response. The channel is going to open up and medications are going to enter the cell. The usual functioning of the cell changes, and that in turn is going to change physiological functioning. Now, when medications bind to a receptor, they can have one of two possible reactions. Either they can, one, enhance cellular functioning, or two, they can block cellular functioning. Now, there are many medications that do interact with receptors, but there are several that do not. First example that comes to mind of a medication that doesn't affect with receptors would be aspirins, acetylsalicylic acid. Okay, so the ideal drug, and there is no such thing really as an ideal drug. Most drugs have their drawbacks, have their adverse effects. They're not perfect. But what we look for is a drug that is effective or that does what it's intending to do. The ideal drug is safe. It doesn't cause disability, death, or severe adverse effects. And that is also selective. Also, some other things we look for: reversibility, ease of administration, and no interactions with other medications. Now, adverse drug reactions, part of a broader term. Side effects are adverse effects that often occur because the drug interacts with other cells as well as the target cells. Other adverse drug reactions we'll be talking about are toxicity, when concentrations of the medication in the bloodstream get so high that they cause some harmful effects. We always look at allergic reactions too. Our body may reject a medication and cause sensitivity reactions to the medication. This can lead, in some cases, to a type 1 hypersensitivity and cause anaphylaxis, which is a medical emergency. Dependency is another term I'd like you to be able to explain, and dependency indicates when we need more of a particular type of drug to exert the same effect. Carcinogenic effects, when the medication can be cancer causing. And this is true, ironically, of many medications that are used to treat cancer. Then finally, teratogenic effects. Medications have effect on pregnant moms and the fetus. So a quick word on drug nomenclature. I know that you've studied this in Nursing 1, so I'm just going to run through it very, very quickly. The chemical name is not something we're usually concerned with, which is fine with me because they're rather lengthy and difficult to pronounce. The chemical name identifies the drug's atomic and molecular structure. Now, you'll probably use the generic name, and in fact, NCLEX will ask you about medications using the generic name. So it's important for you to start remembering some of the generic names of the medications that you'll be studying while within the nursing program. It's assigned by the manufacturer that first develops the drug. So in this case, ibuprofen, all right, and NSAID, generic name, ibuprofen. The trade name or the brand name, those terms are interchangeable, would be the name that's copyrighted by the company that sells the drug. So that would be Motrin. So I'm briefly going to talk about some of the legislation and standards that regulate the use and dispensation of medications. I'm not going to focus on it. I just wanted to simply give you an idea that some of the laws and policies in effect today didn't just pop up overnight, that they had been developed well over the last century. So the first one would be the Pure Food and Drug Act of 1906. It called for accurate labeling that described the indication and use of the medication. Prior to this law, anyone could package any combination of substances together and simply say that it treats heart failure or the common cold or pneumonia without providing any kind of evidence at all. So the purpose of this medication was to eliminate any false or misleading claims. The Harrison Narcotic Act of 1914 worked at curbing drug addiction. Opium was a medication that had been traded in a lot of the old empires, the Dutch, the English, the French empires, all relied in great part on the trade of opium. It was readily available. So this act of 1914 helped to regulate the importation of opium and cocaine and all of their components, and also signals the first time that the term narcotic was used. The Federal Food, Drug, and Cosmetic Act of 1938 led to the formation of the federal agency, the Food and Drug Administration. Food and Drug Administration was given the power to enforce, to regulate the effectiveness of medications, and also called on manufacturers to undergo 3 stages of testing in order to determine safety and effectiveness. The Durkheim-Humphrey Amendment in 1952 led to the differentiation between prescribed drugs and over-the-counter drugs. Over-the-counter drugs requiring no script. Another feature about the Harris-Kefauver Act, medications must be shown to have effectiveness. So any medications already on the market should be researched. And if it was found through research that they had no value, then they were to be removed from the market. The Comprehensive Drug Prevention Control Act of 1970 provided increased research into the prevention of drug abuse and dependence, called for provision of treatment and rehabilitation services, and led to a classification for use and abuse potential of narcotics. What we call a U.S. drug schedule. Now, the different categories of scheduling are based on their potential for physical and psychologic dependency. Drug Schedule 1 would have the highest abuse potential. Originally, these medications were thought to have limited or no therapeutic use, although we find more recently that marijuana does have beneficial effects. The treatment of glaucoma, it reduces the nausea associated with cancer treatments. So in some cases, states like North Carolina have added a drug schedule 6 for substances like marijuana. With drug schedule 2, abuse potential is high, and that goes for physical and psychological dependency. Morphine, which is often used for severe pain. Cocaine, used in surgeries of the nasal passages because cocaine has very potent vasoconstrictive effects and can reduce bleeding during nasal surgeries. So it's often used in that regard. When we get to drug schedule 3, we're talking about moderate abuse potential. Medications like codeine, some barbiturates are used therapeutically. Schedule 4, we get into lower physical and psychologic dependency. So diazepam, alprazolam, which fall into the category of benzodiazepine, have some abuse potential, but are used therapeutically. Then finally, the lowest level would be Schedule 5, and these would be cough medicines with codeine, medications like diphenoxylate with atropine, which is used for the treatment of diarrhea, would have the lowest potential for dependency. Okay, with the FDA Modernization Act of 1997, this act was passed in response to increased incidences of cancers and also HIV and AIDS. And it called for a fast track system where medications wouldn't necessarily go through the very lengthy process of research in order to be brought to market. In addition to the features that are listed on this slide that I'll have you read at your own leisure, it introduced black box warnings. And I have a few examples of these on the next slide. And it derives its name from the dark black border around each of the warnings posted on the medication information sheet. Black box warnings have to do with severe effects of medications. Prozac, fluoxetine, a selective serotonin reuptake inhibitor. The warning here is about possible increased suicidality, so that when we give out medication as effective nurses, we're always going to ask about the presence of suicidal ideas. Upper left-hand corner, propylthiouracil, also known as PTU, a thyroid medication. In some cases, severe liver injury and liver failure has been reported in clients treated with this medication. All right, so as far as research goes, research is a lengthy process. It goes through controlled trials, a controlled trial being research that tries to reduce the variables or factors that can affect the outcome of the research. Researchers will use randomization. Research will also use blinded studies so that the participant in the research doesn't know what the medication is that they're being given. So the timeline is listed in your text. I would encourage you to go back for fuller explanations of all these. Very simply put, clinical tests can last anywhere from 6 to 15 years. There are preclinical as well as clinical phases of the research. The preclinical involves interactions of medication along with tissue or cellular samples. It's done in lab. It might be done with animal tissue. It could be done with human tissue. Very few medications make it out of this phase of the research. Once a medication does, we enter the clinical phase. Phase 1 is used with very small samples where we look for effects of medication. Phase 2, we look at effectiveness of medication. Is the medication doing what we expect it to do? We look at contraindications. What conditions are present that would warrant avoidance of this medication? And then finally, we look for the dosage. Phase 3 involves the new drug application process, where data is sent to the Food and Drug Administration to be reviewed for safety and effectiveness. If it passes, it's put on the market. And then phase 4 ensues, where post-marketing studies occur. We look at the larger population and we continue to look for safety and effectiveness of the medication. All right, so where do we find drug information? Well, I don't know about you, but as an RN, I'm happy to go right for the drug guides for nurses. It tells me everything I need to know as a practicing RN. There are some other sources as well. The U.S. Pharmacopoeia National Formulary, if you want to thumb through 164 chapters and 2,500 pages, it'll give you everything you need to know about medications. There's also the Physician's Desk reference, financially supported by pharmaceutical companies. But like I say, look through the drug guides for nurses or your textbook. We never want to forget the nursing process. It provides one of the frameworks for our practice. And when we're administering medications, we always want to start off with an assessment and assess directly before giving the medication. You do this every time you give out medications in clinical, and every time that you do your medication skill examination in lab. All right, so when we assess, we're not only going to ask about some of the items listed on this slide, like allergies, current medications that the client is already taking, their ability to administer, or our ability to give the med to the client. If we're going to give a PO med, we certainly want to check to see if that patient has any swallowing impairment or not. And finally, we'll look at client knowledge. Ask them what they know about the medication. Ask them if they have any questions about medications. Some other medications that we'll ask in the course of our assessment could include what brings you to the clinic today? An open-ended question where we get an awful lot of information, and then we can selectively choose to focus on particular complaints. Ask, is there pain? Are you experiencing any symptoms? We'll ask about medical history. That's very important, a priority question, because it gives us some clue as to why clients are taking medications. Find out if there's chronic conditions, acute conditions, and if there are acute conditions, when they started. Ask if any other members of the family are affected by the same symptoms or not. Check the skin when giving topical medications. Check for client treatments. Are they adhering to their treatment? When we check medications, check the type of med, the name, the dose, frequency. Check for over-the-counter. Check for any herbal or complementary, which can also affect, be sometimes contraindicated with medications that are being taken. Check for smoking, alcohol abuse, street drug abuse. Check overall health. Last time the client saw a provider. Ask about diet, exercise, any cultural influences. Ask about sleep, sex hygiene, presence of depression. For women, ask reproductive questions. Is the client pregnant? And once we collect all these assessment criteria, we'll look at possible nursing diagnoses. Now, some of the most common when dealing with pharmacology would be ineffective health maintenance, where the client may not be doing everything they can possibly do to maintain an optimal health level. Check for aspiration possibilities, another possible nursing diagnosis. Risk for poisoning or risk for injuring. These are other possible nursing diagnoses. We also want to look at the possible cause, the etiology of the nursing diagnosis. And then we develop a SMART plan. Signs and symptoms will improve by a specific date. Client will maintain a normal white blood cell count by a certain date. Client will demonstrate effective administration of insulin by particular date. When it comes time to implementing or administering the medication, we want to do a secondary assessment. Okay, assess the client, understand why the client's taking the medications. Remember your 5 rights and 3 checks. Make sure that you calculate the dose effectively, accurately. Use proper technique when preparing. Document timely as soon as you've given the medication, not before. Then finally, we want to follow up with evaluation of the client. All right, another term important for you to understand, and we'll be delving into this a little more deeply than you did in Nursing 1, and that is pharmacokinetics. Now, I encourage you to look at some of these terms that we're using and break them down and look at the prefix as well as the suffix. And look at the prefix, pharmaco, dealing with medications. Kinetics, dealing with movement. So pharmacokinetics involves the movement of the medication throughout the body so that the medications reach those target cells. It might sound easy, but these medications do have to cross a lot of structural barriers in the body, which were designed to keep out foreign substances, poisons, and allergens that don't belong. So the medications have to cross some of these structural barriers, which might include the acidic environment of the stomach, plasma membranes. In addition to that, medications have to withstand chemical influences in the body. There are areas of the body that are highly acidic, like the stomach, areas in the body that are highly alkaline, like the intestines. So the medications have to withstand the chemical influences that are present. So the plasma membrane protects the cell against foreign invaders. The plasma membrane is lipophilic. All right, again, break down that word lipophilic. Lipo having to do with lipids or fats, and philic having an affinity to. Lipophilic, fortunately, most medications are lipophilic. They have an affinity for the type of membrane that exists on the cell. And so lipophilic medications tend to interact well with the cell. And one of the principles I'd like you to remember when we talk about medication absorption and distribution is that like dissolves like. So lipophilic medications readily cross plasma, more readily cross plasma membranes, as opposed to hydrophilic medications, which have more of an affinity for water. So when we're talking about medications that cross the plasma membrane, smaller molecules tend to cross very easily, whereas the larger molecules will need some help. Either they'll have to bind to carrier proteins, or they will need a source of energy, like active transport, in order to help them cross that plasma membrane. So here are the different categories of pharmacological processes, and we'll go through each one by one, starting off with absorption. All right, movement from the site of administration into the circulating fluids, the bloodstream, in other words. So it's taken orally, rectally, medication moves from that site of administration into the bloodstream. Now, absorption varies based on several different things. The speed of absorption determines the onset of action. The onset being the time at which the medication starts exerting its effect. And this can vary. Some medications have an onset of 30 seconds or so. Others will take several hours. Other influences on absorption include the formulation. Liquids tend to absorb quickly, where extended release or delayed release medications tend to act slowly. So for PO medications, the fastest absorption would involve the buccal formulation, then the elixirs, then suspensions, powders, capsules, tablets, and then the extended release. Other factors would include the dose. Generally speaking, the higher the dose, the faster the absorption. Ionization. Ionization has to do with the composition of the medication and its influence by the pH surrounding it. So gastric pH is very low. It's an acidic environment. So a medication like aspirin, also known as acetyl salicylic acid, absorbs very easily. Remember, like dissolves like. Now, once that aspirin enters the intestine, it becomes ionized and doesn't cross the membrane as easily. Distribution has to do with movement of medications throughout the body. It's determined by several factors, determined by blood flow. We need an adequate amount of circulating blood to move that medication to the target cells. We need an effectively pumping heart in order to move circulating fluids. Also, there are some areas of the body that receive a greater blood flow than others, that are more greatly perfused than others. These would include the heart, brain, lungs, and liver. So that medications tend to reach these areas first. Tissue like skin, adipose, and bone aren't as greatly perfused, so the meds tend to reach those areas later. Now, I mentioned chemical composition of medications, and that can affect the pharmacokinetic processes. Lipid solubility, lipophilic medications, is a good characteristic for medications because they allow medications to cross the membrane. So finally, one last term on this particular slide, and that is affinity of tissue for medications. Affinity has to do with the body's ability to store medications. Specific tissues have affinity for specific medications. Adipose tissue, for example, has great affinity for benzodiazepines like Valium. Teeth have affinity for tetracycline. Eyes, bone marrow have high affinity for other medications. So what happens is that these meds can be stored and then released into the circulation over several weeks or months. Now, some potential obstacles for distribution. One I want you to focus on would be the drug-protein complex. Drug-protein complexes are large molecules that develop when medications bind to plasma proteins that circulate in the bloodstream, plasma proteins like albumin. These complexes continue to circulate until they break apart. The problem is that the complexes are too big to cross capillary membranes. The medication has to circulate freely, has to circulate by itself in order to cross capillary membranes and reach the target tissue. Some medications are highly protein bound. They tend to bind to these proteins. Fortunately, the body seems to sense when it needs more of a medication. The drug will break apart from these complexes, circulate freely, cross the capillary membranes, and reach the target tissue. Problems can occur when you're giving two medications that are both protein bound. Textbook example would be aspirin and warfarin. Warfarin, a commonly used anticoagulant. Aspirin and warfarin tend to compete for the same plasma proteins. Aspirin might displace warfarin, so there is more warfarin circulating. That, as you can imagine, could develop into problems with the patient's ability to form a clot and lead to more bleeding. What's important for us to do as RNs is monitor blood levels of albumin in certain patients. The liver form albumin. So we're going to monitor, we're going to assess clients that experience liver diseases like cirrhosis, like HIV or AIDS. We're also going to monitor older adult populations because the body's ability to form albumin decreases as we age. In addition to that, monitor clients that are experiencing starvation, clients that have experienced extensive burns because the body's ability to develop albumin could be impaired. So if albumin levels are too low, I want to emphasize there may be too much circulating medications. All right, let's move on to blood-brain barriers. Large molecules tend not to cross into the central nervous system. And the physiological reason for that is to prevent the entry of toxins into the nervous system. However, large molecule medications might have a difficult time crossing over. Certain medications, fortunately, cross more easily, and these would include sedatives, anti-anxiety medications, and anticonvulsant medications. Finally, another potential obstacle would be the fetal placental barrier, and you should not prescribe any medications before asking about pregnancy. All right, we'll talk about medications and their effects on the pregnant mom and on breastfeeding in next week's lecture. All right, metabolism, also known as biotransformation, involves several different chemical reactions like oxidation, chemical transformation when a molecule combines with oxygen, hydrolysis when waters and salts combine to form an acid and a base, or reduction when a substance gains an electron and another substance loses electrons. So metabolism, also known as biotransformation, can involve some of these chemical reactions. Metabolism converts the medication from an active form into an inert form. Most medications are lipid soluble, and in order to excrete the medication through the kidneys, they have to be converted into a water soluble form. In addition, metabolic processes converts the med into an inert form so it doesn't continue to collect, so it doesn't increase in concentration and result in toxicity. Primarily, enzymes in the liver are responsible for most metabolic processes, the most common probably being CYP3A4. Now, again, I encourage you to monitor clients that might possibly have impaired liver functionings or don't have fully developed liver function. Preemies and neonates have immature livers. They don't readily produce the enzymes necessary to metabolize meds. Hence, there could be a tendency towards toxicity. In addition, older adults, long-term alcohol abusers, clients suffering from liver impairment may be unable to produce these enzymes and might be unable to metabolize medications. There are also genetic effects on metabolism. Certain members of a race metabolize slower than others. About 8% of Caucasian Americans carry alterations in the enzymes needed to break down medications. To use a slang term, poor metabolizers. In addition, certain members of the Asian population metabolize codeine very slowly. So we have to assess these clients for possible toxicity. Something I'd like you to focus on would be the first pass effect. So with the first pass effect, PO meds or absorbed into the digestive tract. They absorb, reach the circulating fluids of the body, where they travel through the hepatic portal circulation. They reach the liver. Once they reach the liver, they are metabolized and form metabolic byproducts, converted into inert forms before they get the chance to reach target tissue and exert their effects. As a result, certain medications require higher dosages when they're given PO because of this first pass effect. Because we know that when we give the medication PO, it's going to travel quickly to the liver, be metabolized. There'll be less active forms of the medication available. Now, other routes like intravenous or rectal, travel almost immediately into the bloodstream and can bypass the liver. As a result, when we give medications through these routes, that same medication, we would need to give lower dosages because there'll be more medication available to reach the target tissue. Last step in the pharmacokinetic process would be excretion, right? The removal of the medication from the body. Mostly it's done through kidneys after the medication's been converted into a hydrophilic form. Smaller molecules will pass readily through the glomerulus, and the larger ones through the renal tubule. So the larger molecules tend to blower when traveling through the renal tubules. Excretion of medications can also involve the lungs. The volatile anesthetics are excreted through expiration. So it's essential, because of so many other reasons, to constantly check airway, check respirations in that client in post-anesthesia. Make sure that they are excreting any volatile anesthetics that are given. IV fluids can be excreted through sweat or saliva, which is why some IV antibiotics tend to give you kind of a funny taste in your mouth when you receive them. Remember also that clients that have any impairment in kidney functioning, end-stage renal clients that are at risk for building more concentrated levels of the medication and are at risk for drug toxicity. Next topic, drug plasma concentration. Now, when we're giving medications, there is no way we can measure concentration of the medication at the target tissue. But we know that when medications reach a certain concentration in the bloodstream, we know they're in a therapeutic range, that they are likely to be doing the job for which they mean. We also check serum levels, not only to ensure that we're giving enough of the medication to remain in therapeutic range, but that we're giving enough of the medication that we're not entering toxic levels of concentrations as well. So let's look at this graph. It's provided by your text. The minimum effective concentration. That's the level at which the minimum level at which the medication will produce an effect. This point in the graph right here represents the peak, all right, the highest level of the medication concentration. Termination of action would represent the duration, the length of time the medication can have an effect. So onset is the time it takes to produce an effect. The peak, the time at which there is the greatest concentration of the medication in the bloodstream, and we never want that peak to exceed toxic concentrations where it can do damage to the body. And then the duration, the length of time the med can have an effect. We want to maintain the serum concentration within the therapeutic range. If we maintain the concentration of the medication between these two levels, the MEC and the toxic levels, should continue to have a therapeutic effect. Another term I'd like you to focus on would be the half-life. Half-life is the amount of time. It's not dosage. It's not amount of medication. So it's amount of time needed to reduce the concentration of a medication by half. The longer it takes a medication to be excreted, the longer the half-life. So a med with a half-life of 10 hours would take longer to be excreted and would continue to have an effect on the body more than a medication with a half-life of 5 hours. Drugs with short half-lives should be given more frequently than medications with longer half-lives. And then conversely, drugs with longer half-lives should be given less frequently. So again, we want to try to maintain a medication within that therapeutic range, the levels of serum concentration at which the medication can have a therapeutic effect. With most medications, it takes about 4 half-lives until there's a balance between the amount of the medication being administered and the amount being eliminated. In other words, 4 half-lives until a therapeutic level can be maintained. Sometimes we want a medication to reach that therapeutic range more quickly. If you look at the graph, notice that drug A takes about 6 doses until it reaches that therapeutic range. Now, if we're treating an infection, we want that medication to reach therapeutic range much more quickly. We don't want to wait 6 doses. In that case, we might give what's called a loading dose, right? A loading dose. An increased amount of the medication at first, so that the med concentration quickly reaches the therapeutic range. After which, we would give maintenance doses to keep the drug at therapeutic levels. So look at drug B. We give an increased dose of the medication, and then it'll reach the therapeutic range within 12 hours, as opposed to 60 hours if we were just giving standard dosages. All right, so we give an increased amount of that medication at first. The concentration reaches the therapeutic range, and then we give maintenance doses. So a few more words about receptors. We're almost there for today. Receptors allow drugs to work by forming a chemical bond with the drug. The medication and the receptor have to have a comparable chemical shape. Just like enzymes in the body, medications work in a lock and key relationship. They have a comparable chemical shape, they fit into the receptors, and the better the fit, the stronger the drug's affinity for the receptor, which means the better the fit, the lower the dose will be needed for a response. Now, when medications react with those receptor sites, it can have one of 3 effects. An agonistic effect, where the medication interacts with a receptor and produces a response, and sometimes produces a heightened response of the cell. An antagonistic effect involves interaction with a receptor that inhibits or prevents a response. Beta blockers are also known as beta antagonists. They bind to a receptor site. They prevent usual and chemicals in the body from interacting with that receptor site, thereby inhibiting the response of the cell. Partial agonists will produce a weaker, less effective response, a positive response, but less of a response than an agonist. Now, textbook case for a partial agonist would be the narcotic Talwin, which is a narcotic that provides pain relief, but without the euphoric effects of a stronger medication like morphine. And so Talwin is often used for severe pain in clients that might have narcotic abuse issues. Okay, variations to drug responses, the placebo effect, that mind over matter, genetics, our age, which we'll get into next week, and pregnancy and lactation. All of these can provide variations to drug responses, and we'll talk about them more at a future date. Have a good week, everybody. If you have any questions at all about this presentation, kindly let me know. Take care.